انا مش شايف حاجه، انا عايز الشاشه قدامي كلها، يا اما تديني بقى مايك واتكلم وانا واقف كده، لو مايك هيبقى احسن. Yes. Confronting obesity to prevent cardiovascular disease action is now. The definition of obesity now is serious, chronic, progressive, relapsing, and treatable, multifactorial, and neurobehavioral disease wherein an increase in adiposity promotes adipose tissue dysfunction and abnormal fat mass physical forms, resulting in adverse metabolic, biomechanical, and psychological health consequences. Obesity rates are increasing worldwide, and Egypt now have a high rate of obesity, which is growing on. And obesity at age of 2 predicts status of at age of 35. So 57% of today's children will be living with obesity at 35 years old. Obesity is an increasing health burden because the total of 1.25 billion people are predicted to have living obesity by 2030. And the obesity is associated with multiple comorbidities which equal 229 plus complications affecting every organ system and medical specialty. People with obesity are at higher risk for comorbidities. Evidence from the United Kingdom primary care database show it causes diabetes, hypertension, dyslipidemia, sleep apnea, osteoarthritis, asthma, heart failure, and atrial fibrillation and chronic kidney disease. The increased risk of cardiovascular mortality is very high in male and female. Although the people, if they are severely obese or overweight, we find the mortality is very high. Overweight or obesity increases the risk of cardiovascular events, even in the absence of metabolic abnormalities, as we see from this slide, by having coronary artery disease and the cerebrovascular disease. Obesity is a major driver for cardiovascular risk. The European Society of Cardiology clinical consensus about obesity show that the main cardiovascular consequences of obesity is cardiovascular risk factors like diabetes, hypertension, dyslipidemia, obstructive sleep apnea, arrhythmia, atrial fibrillation and sudden cardiac death, thromboembolism, deep venous thrombosis and pulmonary embolism, atherosclerosis in the form of coronary artery disease, peripheral arterial and cerebrovascular disease, heart failure like heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, which is very important because we have an observational study with the European Society of Cardiology, which is called long-term observational study for heart failure. We find in Egypt that we have many HFpEF patients, which women and are obese. The valvular diseases like aortic valve stenosis. The adiposopathy, the dysfunctional fat underlies disease status, as we see. If we look here, we'll find that the adiposity, as a final end here, causing the congestive heart failure, stroke, and chronic kidney disease, plus coronary heart disease and other diseases due to the adiposity, as increasing the adipose synthesis, increased lipid production, increased activity of the sympathetic nervous system, increased activity of the renal angiotensin system, and the mechanical stress. The prevalence of complications in people with obesity, as we see, 3% stroke, 3.5% congestive heart failure, 8% ischemic heart disease, and 21% myocardial infarction, and 51% hypertension. Okay. So how does obesity lead to metabolic heart disease? As we see, the fat mass diseases increase the cardiac workload, left ventricular hypertrophy, fibrosis, leading to AF and heart failure, whatever it is, HFpEF or HFrEF. The adiposity causes insulin resistance, hyperglycemia, dyslipidemia, hypertension, systemic inflammation, hypercoagulability, leading to ectopic fat in the liver, in the islet of pancreas, in the muscle, in the heart, all lead to atherosclerosis and cardiovascular disease. The question for the cardiologist, does obesity contribute to heart failure, preserved ejection fraction? Yes, because increasing leptin levels causing increased renin aldosterone activation, decreasing PNA levels, leading to increase the plasma volume, increase the sodium levels, increase inflammation, cardiac fibrosis, renal fibrosis, arterial stiffness, all together causes stiffness of the left ventricle and the filling pressure, leading to clinical HFpEF. So the obligation to act is very important. How early should we start to manage people with obesity? We must know that the timing of treating obesity should not be too late. It should be rapid. Rapid by decreasing the liver fat, decreasing the glucose, decreasing the triglyceride, and decreasing blood pressure if it is days or weeks. But intermediate, likely few months, we will have favorable cardiac remodeling. But if we continue to treat having weight loss, we will have likely years, will decrease the atherosclerotic cardiovascular disease, and GLP-1 now has a benefit likely to be a direct effect. For how long should obesity be treated? Early treatment reduces exposure to excess adiposity. Multiple mechanisms favor weight regain after successful weight reduction. If we start too early, we will increase the PNS tone, decreasing the sympathetic nervous system tone, the satiety, the T3, T4, TSH, and leptin, increasing the muscle efficiency and adaptive thermogenesis, increase hunger and food reward, decrease the satiety, food restraint. All these factors all together will be early, but we have to keep it and to keep treating obesity and not to stop obesity, because once you reduce weight, the weight is regaining again. These are the conditions that improve the medical obesity treatment: glycemic control, hypertension, dyslipidemia, systemic inflammation, and the sleep apnea, HFpEF, MACE, cardiovascular mortality, all-cause mortality, and the quality of life. The benefits of weight loss according to the percent. If we reduce from 0 to 5%, we will reduce the hypertension and the hyperglycemia. From 5 to 10%, we will prevent type 2 diabetes, the dyslipidemia. If we reduce it from 10% to 15%, we reduce the cardiovascular disease, urinary stress, incontinence, and MASH, and GERD. More than 15%, we will prevent HFpEF and cardiovascular mortality. So we have toward greater weight loss and overall health improvement. The guidelines of the European Society of Cardiology recommendations in 2023, it is recommended that individuals living with overweight or obesity aim to reduce weight and increase physical exercise to improve the metabolic and overall the cardiovascular disease risk profile. This is class 1A. This is in the European Society of Cardiology for the recommendation to prevent the type 2 diabetes plus cardiovascular disease. The clinical evidence of novel obesity medications now are in our hand. We have in the arena of the reduction of the obese patient, we have the GLP-1 with proven cardiovascular benefits. We have 3-point MACE reduction, non-fatal MI, non-fatal stroke, and cardiovascular deaths. If we look for the liraglutide, 13% risk reduction. For the dulaglutide, 12% risk reduction in MACE. For the semaglutide subcutaneously, 26% risk reduction, as we see from this important slide. 20% reduction of MACE reduction with the semaglutide for the primary cardiovascular composite endpoint, heart failure composite endpoint, and deaths from cardiovascular causes, deaths from any cause. The changes in cardiovascular risk factors in the SELECT trial show that waist circumference is decreased by 1.3 centimeter with placebo. The systolic blood pressure is decreased. The high sensitivity C-reactive protein, which is very important, is decreased, which is residual risk factors, the total cholesterol levels is decreased by 1.29, and the triglyceride levels is also decreased. So we have here the importance and the evidence based from the semaglutide, which reduce the clinical outcomes of HIF-PIF pooled analysis by 31% reduction in risk. And semaglutide also may have decongestive and disease-modifying effects in the HIF-PIF patients. As we see, there is a much reduction in the NT-pro-NP when they given to those patients with HIF-PIF, and also had an effect on the left atrial volume and other parameters. Semaglutide also improved the E-wave velocity, the AA ratio, and the echocardiography, and right ventricular remodeling compared with placebo. And so we have many effects. Not only the HIF-PIF, but also they have effect on the HIF-RIF or the heart failure with reduced ejection fraction patients. And if you compare all the studies that made for heart failure patients, for example, like the Parallax, the Paradigm, the Ember, the TOCAT, the Imperial Preserved, the Deliver, the Determine, and the Preserved, we'll find that the step HIF-PIF using semaglutide, we have a high magnitude of quality of life by using the Kansas City score. Also, semaglutide has a greater effect in patients with HIF-PIF and atrial fibrillation, and also tirzepatide improved the outcomes in people with HIF-PIF and obesity. So we must know that there is an additional effect of the GLP-1 receptor agonist as an anti-atherosclerotic effects, as we see, have a direct effect by improved endothelial function, increasing nitric oxide, decreasing the ECAM for the inflammation, decreasing vascular smooth muscle activation, decreasing proliferation, decreasing the vascular inflammation, decreased lipid accumulation. All these are affecting the plaque and affecting the stability of the plaque. So, and have an indirect effect by decreasing the blood pressure, decreasing weight, and decreasing HbA1c. The guideline recommendations for obesity management in primary care stated that reducing cardiovascular risk in people with and without diabetes in the 2024 European Society of Cardiology guidelines for the management of chronic coronary syndrome, semaglutide should be considered in overweight patients with body mass index more than 27, or obese with a chronic coronary syndrome patient without diabetes to reduce cardiovascular mortality, myocardial infarction, and the stroke, and the class 2A. In 2023, the guidelines for management of cardiovascular disease in patients with diabetes, GLP-1 with proven cardiovascular benefit are recommended in patients with type 2 diabetes and atherosclerotic cardiovascular disease to reduce the cardiovascular events independent of baseline of the target HbA1c and independent of concomitant glucose lowering medication. This is class 1A. So the ideal patient for cardiovascular risk reduction with GLP-1 the following patients are patients with atherosclerotic cardiovascular disease and type 2 diabetes, patient with coronary artery disease and body mass index more than 27, and patients with heart failure with preserved ejection fraction and body mass index more than 30. So the cardiologist rule in obesity management in their patients consider multidisciplinary approach with diabetes and endocrinology specialist in patients with diabetes, particularly diabetes that has been difficult to control. Obesity and overweight is a modified risk factor for cardiovascular disease. Cardiologists need to be able to take this on and initiate or manage the therapy as with other modifiable risk factors. My final remarks: obesity is a complex condition, drives cardiovascular disease via interlinked mechanism, and targeting obesity can improve cardiovascular outcomes, lifestyle changes, medications, or surgery. Addressing obesity is key to reducing the global burden of cardiovascular disease. Reducing excess body weight can lead to improvement in cardiovascular risk. And thank you very much for your attention.
دكتور عاطف، نشكر حضرتك لاوفر فيو رائع وسريع كده، يعني حضرتك خسرت فيه اكيد على قد ما تقدر، بس الحقيقه ادانا اوفر فيو رائع. انا عايز اسال حضرتك سؤال سريع، ويمكن زملائنا في السكر يوافقونا ولو يحب حد يشارك. الاوبيسيتي بارادوكس، هل is it a myth or a fact؟ ان في اراء هنا وفي اراء هنا، وفي راشونال هنا وفي راشونال.
اعتقد الدكتور محمد سليم هيقولها لنا يعني، فما نحرقهاش.
طيب خلاص ما نحرقهاش. طيب بالنسبه لاساتذتنا وزملائنا، بتعملوا ايه مع الهيرويك يعني نيدز بتاعت البيشنتس في المونجارو؟ في قصه يعني بنواجهها احنا شخصيا، فما بال حضراتكم بتعملوا ايه؟ بتقولوا للبيشنتس انا عندي مثلا بيشنت عندها 67 كيلو وسليم وبتاخد منجارو عشان تبقى 62 كيلو، ففي ميس يوز وفي ابيوز. حد يحب يعلق؟ عايزين نشوف الاوفر فيو بتاع حضراتكم ايه. فور شور، انا قصدي بنتعامل ازاي معاهم، لان هم
هو في ريكومنديشن، مش مجرد اي واحد اصل انا عايزه اخس او ما اخد مونجارو ولا اخد اوزامبيك ولا في ريكومنديشن. اولا من 27 بودي ماس اندكس لو في ميديكال كونديشن، اوبيز دايابيتك مثلا او حاجه زي كده، غير كده هيبقى من فوق 30. انما هو حد ياخدها وهو عايز يخس 3-4 كيلو، طبعا ده مش
انه بيتعاملوا معاه او تي سي، يعني هي مشكله بس اللي عايز اصدرها ان البيشنتس بيتعاملوا او تي سي، فده دورنا فعلا يعني.
ويحصل مشاكل، والمشاكل بتحصل من كده. احنا على فكره كان في جلسه قبل حضراتكم هنا خلصناها الساعه 6، كانت بتناقش كل الكلام ده، وكنا بنناقش ان في عيانين بياخدوه بدون توجيه الدكتور، وان هم بياخدوا بسرعه، مش بياخدوا الدوزز بالطريقه الصح، بيبقى عايز يخس بسرعه فبياخد بسرعه. الحاجه الثانيه ان في سنترز معروفه تماما بتدي ريجيم كده للعيان. انا شفت عيانين جايبينها لي في ايديهم ان هو مكتوب له دوزز ورا بعض على طول، يعني مش بيقعد شهر وبيقعد بتاع ده، الدوز على طول، غريبه جدا. ودلوقتي بقى في حاجه اسوأ، ان هم التخسيس دي كانت العيان بيروح وهم بيدوا له انجكشن، عنده انجكشن ماكول الماستر، مش عارفين ده ايه، انجكشن حقنه مفتوحه، بيدوا له حقنه مفتوحه مش معروف فيها ايه ولا كونسنتريشن ولا جاي منين ولا اي حاجه. دلوقتي هم السنترز دي ابتدت تخاف شويه، فبقت تبعتها للعيان في بيته سرنجه مفتوحه
كمان
فيها ماده، فيها ميه جوه، مش عارفين دي ايه. عندي عيانه سمعت ان هي كانت بتقول لهم انا عايزه حقن تخسيس، قالوا لها طيب تكلفتها كذا، قالت لهم معيش الفلوس دي، فقالوا لها معاكي كام؟ بعتوا لها شويه بالفلوس اللي معاها، يعني قالوا لها خدي ادي حقنتين حاجه كده، يعني موضوع بقى قمه العبث.
هو محتاج ستيتمنت من حضراتكم لو في توصيات، لو في حاجه، لان فعلا احنا بنشوفها في بال حضراتكم اللي بتشوفوها عشرات الاضعاف اكتر مننا يعني.
عبث يا فندم، مش احنا بقى، المفروض الوزاره. بصراحه.
في حد من فلور يحب يسال اي حاجه؟ نشكر الاستاذ دكتور عاطف.
شكرا.
اتفضل يا فندم. سلايد.